Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and we are wrapping up our Heart Health Month today, and it's going to be all about clinical trials at TMC and getting to the heart of the matter. So I have Dr. Ariana Ehsan here with me, and Dr. Ehsan is our TMC Health Clinical Researcher, and she covers everything that you need to know all about our cardiovascular health. And I know she has a lot of different trials to share with you today. She collaborates with highly trained physicians and global institutions while expanding her expertise on devices and therapies to further develop patient care and influence medical guidelines. Welcome, Dr. Ehsan. How are you today?
Good, thank you. How's everyone doing?
Good.
Everyone here?
Good.
Everyone online?
Yes, so we have an online audience along with an in-person audience today. I'm going to go ahead and put your PowerPoint up for you so that you can get started, and then we'll ask any questions from our online audience once you finish, and then we'll turn it over to our in-person.
Perfect. Well, first and foremost, thank you everyone for having me. Thanks for the online viewers, and thanks for the folks here and someone who's on the phone who wants to hear it too. So my name is Dr. Ehsan. Wonderful introduction. I work with the TMC Clinical Research Department. So I am a full-time investigator. Basically what that means is I'm a physician that works full-time in our clinical research office. I work on all the clinical trials. So if your cardiologist refers you to a clinical trial at TMC, you're probably going to come and see me first before you end up having your procedure. So we have a huge program here at Tucson Medical Center. We have a great number of trials. We are globally recognized, and that's just because we have a lot of folks who need some help with their hearts. So what I'm going to do is I'm going to kind of go through all of our clinical trials, not get in the tiny details because those things can be kind of hard to figure out or a little boring. But let me go ahead and first start with introducing kind of our general team. So if you were here just 2 days ago, Dr. Wagner had a talk. So Dr. Wagner is the medical director of cardiovascular clinical research in specific. Oh. Natalia is the director of clinical research for the whole program, and then myself, I am the clinical research investigator, and then I'm also faculty for our research fellowship. Let's see, is there a way that we can make it not go on its own? Yeah. Oh. Let's see. See if that does it. We'll see. That's where our office is located. We're just on the south side of Grant. So we're just across the street from the hospital. I'm just gonna have to talk really fast. So these are all of our active clinical trials for cardiovascular interventions. I'm gonna walk us through each one. Oh man, it's still doing that.
Click on the yeah.
Wanna try that?
You might have to check every slide.
I have it on all.
Okay. Then if you uncheck after, that should do it, I think. So, yeah. Okay.
All right, so we're going to go ahead and go through each of the trials. I have it split up based off of kind of what the pathology is or what the disease is. So here we have non-valvular AFib. Here we have aortic stenosis, aortic regurgitation, mitral regurgitation, mitral annular calcification, mitral regurgitation with congestive heart failure, our tricuspid regurg interventions, and then patent foraminal valleys. So we do have other clinical trials that we were already a part of, but those are no longer enrolling, meaning we can't bring any new patients in. We're just in that follow-up phase. So the ones that I have on here are just the ones that we're actively bringing patients into right now. So this is what the slide setup is going to look like. And the reason I have this is because some of these things can be kind of confusing, and they were confusing for me when I was putting it together. So I made this partially for myself and partially for you all here. But basically the way it's going to be set up is at the top, you'll have the clinical trial or study name. And then below that, we'll have investigators listed. So the physicians and the nurse practitioners who are directly involved with this clinical study and this clinical trial in specific. And then we'll go down and I have 4 sections. That first section is going to be study design. So in that, what will be included is kind of the setup. How is this clinical trial set up? Is it more than one hospital? Is it just Tucson Medical Center? Is it multi-center? Is it looking at patients in the future, or is it looking at patients who already had an intervention in the past? And then just a brief description of kind of what is being tested and what's the goal. Patient population is who do we think that this intervention is good for? Who can benefit from this? Who could maybe have this procedure and feel better? And then we have primary endpoints. What is this clinical trial or study additionally trying to prove or review or assess? And then lastly, we have the study enrollment goals. And that's very short, but basically what it says is the number of hospitals globally, and then the number of patients that will come into a clinical trial. So before I move on to the next kind of moving on and looking at all of the trials, what's important to understand with clinical trials and clinical studies is that the reason they take place is because in order to make a device available on the market for you to go into your cardiologist's office and your cardiologist to say, you know what, you need this procedure and you need this valve, and I'm just going to schedule you at TMC and we'll have your procedure done in 2 weeks. Before we can get to that point, we have to be able to prove that that device is safe, it is effective, it is reproducible. We can't just put something together and say, yeah, I think this will work for you. Let's see how that goes. We have to be able to prove it, and we have to be able to show all this data that even in the long run, let's say up front, you feel good and we take pictures of the heart and everything looks good, but 30 days later, all of a sudden you're not feeling good and that device doesn't look good. Well, there's an issue there. So that's why we do clinical trials, and clinical trials come in multiple phases. There's the first in human, which literally means it's the first time that procedure is done in a human. And it's been tested in the lab many a time before, but now it's the first time it's going to go in a human. There's early feasibility, which is after first in human, and it ranges from anywhere from 15 patients globally to 50. And then after that, we get into the pivotal trial. And those are the big ones that they enroll 1,000 patients, 2,000 patients, or 3,000 patients. And that's globally. And once that data gets published and the FDA reviews all these, chunks of data as it comes through, the FDA says it is safe, it is effective, it is reproducible. The regular cardiologist down the street can do this procedure and get the same outcome that Dr. Wagner gets at Tucson Medical Center, and patients will be safe. Once the FDA gives that thumbs up, well, now it's available on the market. And you go to your cardiologist's office and they say, you have this, you need this procedure, I'm going to get you scheduled and you'll have your procedure in the next couple weeks. So that's why we have clinical trials. All right, so we had said that our first group was going to be that atrial fibrillation group. So folks that have an irregular heart rhythm, generally those folks who have that irregular heart rhythm, your physician is going to want you to be on a blood thinner. And the reason for that is because you have an increased risk of stroke. There's this little pocket that sits on the top left side of the heart. And I have a model over there, which if you give me a second, I'll grab it so I can show it to you guys.
Here we go. I get to take it apart.
So this will apply for the next 3 that we're going to talk about. If you slice me down like this and you look straight into my chest here, we've got the right side of the heart, left side of the heart, bottom half, and top half. This pocket here is called the left atrial appendage. This room is called the left atrium. So left atrial appendage, basically it's like the appendix of the heart. All it does is cause a whole lot of problems, and it doesn't really do you much good. So folks who have AFib and have that irregular heart rhythm, your cardiologist will want you to be on a blood thinner. And that's because clots can develop in here. And when folks come out of that AFib rhythm and go back into a normal rhythm, the blood clots can pop out of here, make its way into the left ventricle, and often into the aorta, which is like the freeway to the body. And the first exits that come off of that freeway go straight to the brain. So it's super important to have folks on a blood thinner so that we can bust those clots or not allow them to happen. Now, there are cases where some folks either can't tolerate their blood thinner or they can't afford their blood thinner or they don't want to take it. So we actually have trials for both because regularly available on the market, you guys may have seen some commercials for the Watchman that Boston Scientific makes, or there's another device called Amulet. So there are a couple of devices that are already available on the market for folks who can't tolerate that blood thinner. Now we have clinical trials, one, bringing new devices out because my heart is different than your heart, and it's different than your heart, and it's different than yours. So that means this pesky pocket, this appendage here is different in me, and it's to you, and to you. So there's no way to make a one-size-fits-all device. So what do we do for our patients? We try and find different options for them. So the first trial that we're going to talk about is called Catalyst. It's a prospective trial, meaning bringing new patients in. It's randomized, meaning there's a flip of the coin. Half the folks are going to have the procedure and half the folks are going to keep taking their blood thinner. And it's multi-center, not just TMC. If you look down here at study enrollment, 150 hospitals globally are participating in this trial. The goal of this trial is to test the safety and efficacy of the Amulet device, which you can see down there on that bottom left, in closing off this pocket for folks that have AFib but can tolerate their blood thinner. So they want to come off it for another reason. They're really active, they don't want to pay for it, they just don't want to be on another medication. So we're at this point where we can kind of expand. This is Catalyst. This one is called Conform. This is for the folks who cannot tolerate their blood thinner. They do have that irregular heart rhythm, that AFib. They are at increased risk for having stroke, but there's something else that's making it hard for them to be able to continue to take their blood thinner. Those things can be having a stroke. Those things can be having a high fall risk or falling often, because if you're on a blood thinner and you fall and you bump your head or something like that, we get into a position where now we're putting you at risk. Once folks hit 75, the stroke risk increases significantly, but at the same time, the bleeding risk also increases. So we want you on a blood thinner, but at the same time, we don't want you on a blood thinner. So what do? We want to get you off a blood thinner, but still protect you from having a stroke. So if we block this area off by putting a device in, non-battery powered, it goes in, your heart tissue starts to develop a scar over it, and then you come off your blood thinner, this pocket ceases to exist. We don't have to worry about it anymore. It doesn't change being an AFib, but what it does do is it does decrease the stroke risk, because now we've blocked off that area where these clots develop and like to develop. So the Conform trial is for the folks who cannot tolerate their blood thinner, but their device is a little special. If you see it there on the left side, it kind of looks foamy. And the reason it looks like that is because it's actually made of foam. And they're very appropriately named Conform because it conforms to the shape of the pocket. So they only have two different sizes, but those sizes cover a huge variety of pocket sizes. This is HeelLaa. This is with Boston Scientific. This is also for folks who have that increased risk of bleeding, increased risk of stroke with AFib, can't tolerate the blood thinner. This is the Watchman Flex device. It's just the newest version. It has what's called a Hemocode on it. So this cover that it has is very similar to the coverage, or the same as the coverage that happens on stents. So if you know anyone who's had a stent recently or in the past 10 or so years, they have those stents that have medication on them. So it's that same type of coating, and it eludes kind of a blood thinner. which is great for folks who, when we block off this area, we still have to wait for scar tissue to grow. And if that scar tissue hasn't grown yet, no doctor wants to take you off a blood thinner because we still want to keep you protected from the strokes in the meantime. So having that coverage and having that coat on it makes it more possible for us to get you off a blood thinner sooner. So now this device is actually readily available. This is a post-market study, meaning it is available here at TMC. Our structural heart physicians, the plumbers of the heart, the Dr. Wagner's and Dr. Thomas's and Dr. Duval's can do this procedure for you. We're just keeping an extra eye on how well that tissue grows over that pocket and that device to see if maybe in the future, folks don't have to be on a blood thinner after their procedure. That coverage, that hemocoat is good enough to protect you, and we can get you off a blood thinner even faster. This has 60 sites globally, so there's going to be 60 different institutions and a total of 1,000 patients. It already had 500 patients enroll. This picture here is actually from our first Watchman Flex Pro implant within the trial, and it actually made it to be the first. So on October 3rd of last year was the first day that Boston Scientific released this device, and it was all within the trial. So we at TMC got to be the first hospital to go ahead and implant that. So our first Watchman Flex Pro case in Arizona, TMC Health becomes one of only a few hospitals in the nation to offer this option, and the case officially initiates the clinical trial nationally. Now we're going to switch it up. We're off of arrhythmias and we're into general valvular issues. So leakiness on valves or tightness on valves. You may have heard of MicroRgit or aortic stenosis, aside from when I just mentioned them right now. But I have this on here once so we can kind of get the lay of the land, and we can kind of, again, look into the chest here. Here's the heart, and now we're looking at it zoomed in here. And so now we kind of know what each of these valves are. And then I have pictures of French doors, and that's because that is how I always explain valves to patients that come into my office. Because this is nice, but sometimes it's not that easy to imagine what is really happening in your heart when someone tells you you have a leaky valve or if you have tightness on your valve. So, well, what does that actually mean? Each of our valves in our heart, we've got 4 major valves. Easiest way to think about them is each of them is a door. I told you that these were rooms here. Top half, bottom half, right side, left side. Room, 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 and room. Well, the only way for us to get into this room was to come in through that door. The only way to get into these rooms is to go through doors. So if we have leakiness on a valve, and if these are the doors here, well, the way a valve normally works and the way it normally works in the heart is this room fills up with blood, creates enough volume and enough pressure to open this door. And this door opens and it sends the blood off into this room. And the same thing happens all the way through. Someone has a leaky valve. What that means is the door, room fills up, enough volume, enough pressure, door opens, blood goes out, door shuts. A leaky valve means when it's time to shut, that's as far as we're getting it shut. So we're kind of in the middle or off to the side there. We're not shutting all the way. The same way, if we left that door slightly open, we would feel a draft coming from outside. It's the same thing as the blood now rushing back. All that blood that was supposed to move forward, now we get backwash on some of it. So that's how leakiness works. The way that tightness works, or stenosis, the way that works is I put enough blood and enough volume, enough pressure in here, and it's hard to open these doors. And then the heart is a muscle itself, and it has to push. So we can push this door open. And the moment just enough volume goes out and just enough pressure is dropped, those doors slam shut. So it's as if our door kind of expanded in that area, or on the hinges, we got a bunch of calcium buildup all across the hinges and all around the door frame. And so it's going to be hard to open that door. So our valves, just like doors. All right. We'll start with aortic stenosis. So that is tightness on the aortic valve. And you'll see those pictures down there. I also have the valve model here, so you guys can take a look at that. The Accurate trial is run with Boston Scientific. It's prospective, meaning we're bringing new patients in, multi-center, 85 hospitals across the globe, and it's randomized, flip of a coin. Half the folks are going to have this valve, half the folks are going to have the regular valve that we always give folks that have a procedure like this at the hospital. Who would need this? Folks who have a tight aortic valve, they're symptomatic, meaning you're short of breath, you're fatigued, you're feeling weak, you may have some swelling. Some folks aren't outwardly symptomatic, and then after their procedure, they realize, oh, I was symptomatic, and those things that I thought were just slowing me down were actually because it was too hard for me to catch my breath. So on the aortic valve, too hard to open. All right, so we have that calcium buildup along the door frame and along those hinges. So it's really hard. So the way the procedure happens is your door stays in place. You just we come in and we give you a new door frame and a new door. The difference between this valve and what's already available is that those openings that we have, that opening for the aortic valve, near where that door opens is also the opening to the arteries that supply blood to the heart muscle itself. So this room is this room here where the aorta comes off of. If this door here, if it opens, well, we want it to open and then we want it to shut and we want to give it a new door frame and a new door. But what we don't want to do is we don't want to block that side door that's feeding blood to the heart muscle itself. If we block that and we don't get blood to the heart muscle itself, that's a heart attack. So yeah, it's good to get a new door frame, but we want to make sure that you're not having that area blocked off and we're putting at risk of losing blood supply to the muscle itself. So right down there, I don't think, does it have a laser? Oh, it does. So right here, these arms are actually what would hold the natural door out of the way, and it kind of accordions it out of the way so that that opening for the blood vessel that supplies blood to the heart muscle itself stays open. This is the Progress trial. So this is a bit different. It is still for folks with tightness on the aortic valve or aortic stenosis. But the difference is that this is actually for folks who don't have that severe level of aortic stenosis. So these folks right now, the gold standard really is just wait until it gets worse. That's what the insurance approves. Or if you have another valve that also needs to be worked on, then a surgeon says, I'll do both procedures at one time. Cut the chest open, do the procedure that way, put the chest back together, stay at the hospital for a week or two, and then go home. Moderate aortic stenosis, patients can be very symptomatic. You can feel really short of breath or fatigued or weak or have that swelling or dizzy or lightheaded. So now we actually have a trial that allows patients to potentially have this procedure. It's prospective, bringing new patients in. It's randomized, meaning it is still flip of a coin. Half the folks will have the procedure up front. The other half of the folks have to keep doing exactly what they're doing. And the moment they go from that moderate level of tightness on the valve to that severe level, we get them booked for their procedure right away. 80 sites globally, 750 patients altogether. Align AR is a little different. It is still an aortic valve replacement. However, this is for a leaky aortic valve. There is no other device that's currently available on the market. There is no other device that's currently in clinical trials. This is the only device, and it is very close to coming out to being available on the market. We have listed here that it's 30 sites and 80 subjects. There's actually only 18 sites globally that are currently participating in this, and that's just because they just can't make the valves fast enough. So we've already had 180 patients enroll in this trial, and now we're getting another additional 80. So by next year, this company is hoping that they'll be able to submit to the FDA and become available on the market for folks, which will be huge because regular gold standard right now is either keep doing what you're doing or open heart surgery. So this is an option, and everything that we're talking about, everything is either an incision in the groin, an incision in the arm, or an incision in the neck, and the procedure happens that way, 1 to 2 nights at the hospital, and then home. Yeah.
Your sample and those pictures there, does that mean looking at
Like
somebody?
this.
Oh, okay, like you?
Yep.
Okay.
Yep,
Okay.
just like that. Just like that. So these all, I put those pictures too because this one doesn't really have the aortic valve or it doesn't have the pulmonic valve either. So this is really just meant for this pain in the butt pocket. But I really like it because it does give you a good idea.
Is that pocket, is that where they were sending the Watchman goes?
Exactly, yep. And I have a Watchman here so we can play with them and I can put it in for you. And I have an amulet device and I also have a Conform device so you guys can see what they look like in here. So the Align-AR trial is for folks who have a leaky aortic valve. We are now on to mitral regurgitation. All right, so leakiness of the mitral valve. This EFS, when you see that, that means early feasibility. The first in human trial has already happened. Now we're in that EFS stage. So it's still very early on in the trial, but that first in human section, that already proved to the FDA that it was safe, it was effective, and it was reproducible. So this looks a little funky. Sometimes I call it a hot air balloon, but it's got a cage. And the reason for that is because it kind of helps and sits up top. So mitral regurgitation, looking back into the chest here, we've got right side, we've got left side, bottom half, top half. This valve here between the 2 rooms on the left side, this is the mitral valve here, okay? So mitral valve, we get a ton of leakiness. You guys may have heard of the mitral clip that Abbott makes. We do that procedure often. That is a clip, so that's a repair option. This is a replacement option. So this is to replace the valve. When that door on the mitral valve doesn't shut all the way, if a clip is not an option, the way clips work is it's kind of like if you open a bag of chips and you don't finish them and you decide that you want to close it and have them later, that clip that we use, it can only open so far, right? If I tear my bag and I put the 2 ends of my chip bag way out here and my clip is only this big, well, I can't grab both of those things. So it's the same thing here with the doors on our mitral valve. If my doors, if your doors are shutting to right here, like the clip can only go so far to grab each side and bring it back together, right? So this is for folks who that clip is not necessarily an option. It's not going to work in decreasing that leakiness. And the symptoms are very similar here. Shortness of breath, fatigue, weakness, lightheadedness, dizziness, swelling in the ankles, swelling in the legs. 20 sites globally, so 20 hospitals globally, 30 subjects total. And I also have this device here so I can show it to you and you guys can get your hands on it a little bit. But this is for patients who have that severe leakiness of the mitral valve. And gold standard for these folks, since that door doesn't shut all the way and we can't get those pieces close together, would actually be keep doing what you're doing or open heart surgery. We have Clasp 2F. This is a clip option. So this is a repair option, and this is comparing itself actually to the mitral clip, which we do have available here at TMC. So those 2 different clips down there, they're made slightly differently, but they are both options within this trial. And they have a slightly different way of having made their repair system in comparison to the mitral clip, but it's that chip clip that's bringing those 2 pieces together so we can help open and shut that door. There's 99 institutions globally and 797 patients will be enrolled. It's prospective, meaning we're bringing new patients into it. It's multi-center. And then it's a flip of the coin, but it's actually for every 2 patients who have this procedure, 1 patient will have the mitral clip procedure, which we already have available. So you get treated as far as procedurally no matter what. High Life EFS is that early feasibility, meaning we're still very early on. Only 15 sites, 15 institutions globally, 50 subjects globally. Single arm, meaning no flip of the coin. If this is the right option for you, this is what you're going to get, okay? Prospective, we're bringing new patients in. Multi-center, we have those 15 institutions globally. And it's non-randomized, which still means single arm. So you're having the procedure. This is for folks who have significant leakiness on the mitral valve, despite all the medications like water pills that we give. If you guys have ever taken furosemide or Lasix, those are it's a very common one, or spironolactone. These are medications that are given to folks when they have leaky valves, and it helps get the water off and the fluid off. So even while being on those medications, if folks are still symptomatic and there's still significant leakiness on that valve, when your doctor goes in to take pictures of it with an echo, that's that ultrasound of the heart from the outside, or sometimes they put the probe down the throat because the heart sits right on top of the food tube and they take pictures of it that way. On those two tests, we can see that leakiness, and we can assess how significant is that leakiness. So even with the medications, if folks are still having those valves that are still significantly leaky, this is an option for them. It's a two-part system. There is a ring and then the valve itself. And if you look all the way to the right, you can see the ring and the valve. So that ring is essentially, if you think about it, it's like a new door frame, and the valve itself is like a new door. I've got two pictures here because we're a little proud of ourselves for this one. This was the first highlight case that happened in Arizona back in January of 2023. TMC Health became the only hospital in the Southwest to offer this as an option to patients. And then I have this one, which is the first in human high life large Annous Valve takes place at TMC Health in July, meaning the first patient in the world to get this new bigger valve size actually happened here at TMC. So we're awfully proud of that. Yeah.
Are all these people involved for this one?
These pictures here?
Yeah.
Yep, so depending on the photo, what you'll see myself, you'll see whoever did the procedure, Dr. Wagner and Dr. Thomas here. You'll see our anesthesiologists, folks from the actual team that work with the company, and then our cath lab staff as well. We can't do anything without them, and our research staff, because I'm not a one-woman show. I have a lot of folks who help me out. So as many people that we can have there because they all contributed to getting this patient there. We don't have pictures of the patients because, of course, HIPAA. All right, we are on to RepairR. So still for mitral valve leakiness, Prospective, bringing new patients in, multi-center, 75 hospitals across the globe, 500 patients total. What we're doing in this one is similar to what we talked about in Progress and similar to what we talked about in Catalyst. We're taking something that's already available on the market and we're expanding the population that we can offer it to. The mitral clip is already available. We just said that when we were talking about Class 2F, right? That mitral clip is already available. If you've got a leaky mitral valve and we can grab both doors and we can bring them together, you're going to get scheduled for your procedure and we're going to get it taken care of. That's for the folks who have the severe leakiness, and open heart surgery is not really an option for them. And, you know, a lot of folks don't want to have open heart surgery. What RepairR is doing is it's actually looking at the folks who have the severe mitral regurgitation. They don't have any calcium there. They don't have any leakiness on another valve, but the surgeon says, well, I could do this procedure and you could have a pretty good outcome. So now we're getting to the point of, remember, a gold standard for these things are open heart surgery. And so now mitral clip is available for folks who open heart surgery is not an option. And we see that the outcomes are so good with those patients. So now I want to see, well, what about the folks who are having that severe leakiness, but the surgeon says, you're not really high risk, you're moderate risk for me to do this surgery. Let's try treating these patients now with this option where we go through the groin and we do the procedure that way, get them home in 2 days, and let's see how they're doing. Because if it's working for the patients who the surgeon doesn't want to do surgery on, well, why wouldn't it work on the folks who the surgeon does want to do surgery on? So we're expanding the population that we can offer this to. Yeah.
So
says here 500 subjects just for this repair.
Yeah.
How many of these people died? How many of these people had no different, I mean, there's no follow-up for me to see.
So as the clinical trials continue to run, when they hit their primary endpoints or they hit certain time points, data is released. So RepairR is not at a point of being released. I can tell you about patients that we have had here. We have had one patient pass away. They did have the clip. The reason they passed away had nothing to do with the leakiness on their valve. The leakiness on their valve had decreased significantly, and it was something else that happened to the patient significantly after they had had their procedure. So as these trials go along and as they hit certain points of, if they enroll for some trials, if it's 500 patients, once they hit 100 patients and 100 patients have their 6-month follow-up, they look at all the data and then they'll publish it at one of our conferences or they'll present it themselves, and then that becomes readily available to all of our patients. This one is Mitro II. This is a bit different. So we've been talking about just leakiness on the mitral valve, but this here is for folks who have a lot of calcium buildup on the door frame, which doesn't happen super often on the mitral valve, but sometimes it does. It's very common for it to happen on the aortic valve, not as much on the mitral valve, but we're happy to have an option for patients who do have a lot of calcium buildup and sometimes still have leakiness on the valve. So generally what that calcium buildup does is it makes it hard to open the door, but on occasion we get that calcium buildup and still somehow the door doesn't shut all the way. So sometimes we have what's called mixed disease, or it's mixed stenosis, which is tightness, and mixed regurgitation, which is leakiness. So this is actually a valve. It's using a valve that goes into the aortic valve space that we had talked about with the Progress trial. That aortic valve that's used normally for that is being used in the space of a different valve, in the space of the mitral valve, because that calcium is what those valves use as kind of like Gorilla Glue to stay in place. So they're testing it out this way, and this is, we're actually doing this with Mayo Clinic. So 25 sites globally, 210 patients. There are a couple different arms in the study. Prospective, bringing new patients in, multi-center. What I don't have written on here though is that sometimes, like I said, that tightness on that valve is uncommon, and this valve may not fit there. And if it doesn't fit there, there's actually an arm within the study called the natural history arm, where you're still in the trial and we still follow you, because if anything new were to come out, if that valve were to be updated and there was a new version of it that came out that was maybe smaller or had something else and it may work for you, we want to be able to still offer it to patients. This one is an in-betweener. This is for folks who have mitral regurgitation, so leakiness on the mitral valve, and also have pretty well documented heart failure. So this is the Empower study. It's the Carillon device. And I've got two pictures there. So this is if you're looking down, it's this valve here. If we're looking down into the valve like this, there are a couple openings to blood vessels here. And the Carillon device, which I also have here and I'll show you guys, will sit in those two openings. And it doesn't block the blood flow into those blood vessels, the blood flow out. But what it does is it will stick itself into those areas and then it gets tightened down. So it comes in like this. So you know how we talked about that leakiness and we're getting all this stretching? Well, what it does is it brings it all closer. So now when this valve is opening and shutting, we have much more chance of that door shutting and getting to where it needs to be. So 75 hospitals globally, 300 patients. This is Corin. So the first picture that we're looking at is we're actually looking at it from the bottom up. So we're in that bottom left room here, and we're looking upwards here. So we're looking up into the mitral valve. I call this a dragon tail. Some folks call it a tennis bracelet. So those are two very different things, but they work kind of similarly. What this device basically does is for folks who have significant heart failure, and they've got stretching out of this bottom left room, okay? And this stretching out goes like this, and our heart is a muscle, and so that muscle has to pump blood out of this room and into the aorta, which is the freeway to the body, and it gets all that oxygenated blood to the whole body. If we stretch this out and we thin this muscle out of it, it can't press down on itself as well, and it can't get as much blood out. So folks start to feel dizzy, lightheaded, shorter breath often, because they're just not getting as much oxygen to the rest of the body the way that they need to. So this device, of course I have a model here, this device actually has little anchors at the end of it, and each anchor goes into the wall of the muscle here. It will go into the wall, and then a slider is put in between, and then another anchor and a slider and another anchor and a slider. And similar to, a coin purse, when you grab the sides and you pull it and it cinches down on itself, that's exactly what's happening here. The same thing happens where this gets cinched, so all that gap in between those sliders comes in tighter. So that really stretched out room will now come in closer. And we see it immediately on imaging during the procedure. And then over the next 6 months, what we see is that on imaging, those ultrasounds of the heart from the outside, we see that the way that we shrunk it down, it's staying that way. And the heart is remodeling and realizing, oh, I don't have to work as hard to try and get myself as close as possible to get all this blood out. So we see that folks' ejection fraction, you may have heard that, what percentage of the blood is coming out of this room, that starts to get better. This here was our first Accusin case. So the device itself is called Accusin. TMC Health becomes the only hospital in the Southwest to offer this option to patients. That was just in August of last year. And we actually just did a case yesterday. We are on to tricuspid regurgitation, so leakiness of the tricuspid valve. We're on to the right side of the heart now. This valve here, kind of call it the forgotten valve because no one has really worked on this valve for quite some time. The surgeons, the open heart surgeons generally will not do a procedure for a patient if they only have leakiness on the tricuspid valve. They usually try and see if you have another issue. Do you also have leakiness on the mitral valve? Do you also have something going on with the aortic valve? And then they'll go in and then they'll do the procedure. So Clasp 2TR is that same clip that we saw in Clasp 2F. This is for folks who are on best possible medical therapy, which generally is those water pills like spironolactone and Lasix and those medications. But they're still very symptomatic and the leakiness is still quite severe on that valve. So those water pills aren't working the way that we need them to work. So this is that same chip clip, bringing it together. Right now, we actually finally have something available on the market for the tricuspid valve. It is a valve replacement. Unfortunately, I don't have a picture here. It's made by Edwards, and we were actually in that clinical trial. So we're really happy to have contributed to it and contributed to data, which was then taken to the FDA, and the FDA said, this is safe, this is effective, and it's reproducible, and we approve it, and we will make it available on the market. So we actually contributed fully to that clinical trial, and now we've seen it come to our shelves, and we're able to offer it to patients. So we are quite happy about that. I wish I had tossed in a picture for you guys. 90 sites, 870 patients, prospective, bringing new patients in, multi-center, flip of a coin. This is Laplace EFS, so early feasibility. This is also a tricuspid valve replacement system. I don't have a picture of the valve, and that's because it is very, very new. So this procedure, unlike all the others, an incision is made at the groin and a catheter that's about the thickness of a pen. Either will go up the artery or it will go up the vein, and it will make its way to where it needs to. If it's going up the vein, it's going to come up this vein here and make its way into this room. If it's working on the tricuspid valve, it flips back around on itself this way. If it needs to make itself into this side, it crosses this wall. We block off this area with a Watchman or an amulet or a Conform. If it needs to work on the mitral valve, it comes up this way, crosses over, and goes down like that. If it's going up the femoral artery, it will come all the way up. It'll make its way up like this and into this bottom left room here. Generally, that's how these procedures are. We're going to go through the vein and we come up this way, or we go up the artery and we come up this way. The difference in this here with Laplace is that it actually uses the jugular. So the catheter is not super long because it doesn't need to make its way all the way up. An incision is made here and the catheter comes down. That catheter actually comes down through this blood vessel. So if you look at it, it lands you right where it needs to be, as opposed to coming up and flipping back on yourself to do the procedure this way. It comes down just like this. And so the valve gets put into place here. 10 institutions globally, only 10 patients because it's early feasibility. Severe leakiness on the tricuspid valve, despite being on all the medications that should help. Yeah.
Does that mean each site only has one patient?
It can. It does not mean that only each site can do one patient. It means that if TMC doesn't do any, we tried to get patients in, but there was one reason or another that it wasn't the right option for the patient. But the next hospital, Piedmont in Atlanta, they now can bring more patients in if it's the right option for them. So it's not attached to how many each site can do. So this here actually was just done on the 19th. Here at TMC, we actually did the first in human Laplace case, and that made TMC the first one within the trial, and that officially initiated the global clinical trial. So we've got one of the 10 down. Yeah.
I have 2 questions.
Yeah.
Do you have an age restriction on any of the people that come into these trials?
So some of them do. All of them, you have to at least be over 18. Some of them say over 22. And then there are a few that the cutoff is 90. But it's actually not often. And some folks laugh at that. And the reason for that is because it takes time for our heart to develop these leakiness issues or this tightness issue, right? So we generally have patient populations who are in their 70s and in their 80s, and I've had patients who are in their 90s, and it just depends per clinical trial. Yeah.
Another question is, from what I understand, women's hearts have smaller vessels. They're not comparable to men's for surgery. I know open heart surgery, men have better outcomes than women. How does that figure into what you're doing?
In general, we see a lot of leakiness with women. So the estrogen that women have actually increase the amount of leakiness. It gives you a little bit more stretch. And so we do see increased leakiness on valves. So we do see a lot of that when I'm looking at my trials for leaky mitral valves. I've seen a lot of women come through. But procedurally, I mean, that's a great question. What we're doing to make sure that these are the right options is there's a lot of imaging that's done. Ultrasound from the outside, sometimes an ultrasound down the throat, sometimes a CT scan. And what the CT scan is doing is it's taking small, it's taking pictures at like 1 millimeter. Takes it here and here and here, and it goes all the way down to the groin. And that way we can recreate the blood vessels and we can recreate the heart, and then measurements can be taken. So measurements of someone's door frame at every which angle can be taken, and then these companies actually use their software systems to virtually implant their device in the heart, and then they look at it from every angle to see, is it actually going to work the way that it needs to? Or when I put my new door frame in, am I going to have this huge gap off to this side? So in order to kind of help with that, we get these very specific pictures, and patients get CT scans for their valve replacements for their aortic valve. So they take 30 to 40 minutes, but they give us so much information, and it allows us to see how thick the walls are and how big the openings are to those blood vessels and any calcium that we're missing anywhere else. So those CT scans are actually quite helpful. Yeah. I really love that picture. That's
That was only 10 days ago.
Yep, yes, yeah. All right, and then we have our last study here, and this is actually called PFO Pass. This is a post-market, very similar to HeelLaa, how we talked about that device is now available at the hospital. We're just kind of going back and looking at it. This is for folks that actually have a hole in their heart. So if we look into my chest here, I'm talking about this wall here between top right and top left. When we're in utero and mommy's tummy, we have a hole here, and that's natural, and that's how we get oxygenated blood where it needs to go. Once we're born, that hole generally closes down, and that's because we scream and we cry and we drink milk and we increase the pressure. And what ends up happening is that tissue that originally was open and kind of had a tunnel to allow blood to go through it when in utero will shut on itself. And just like anything else in the body, it will start to create a scar and it closes off. Some folks will still have that opening. And when they have that opening, what it can allow is blood clots that develop in the legs or blood clots that develop elsewhere without having an irregular heart rhythm like AFib, and without worrying about even this pocket here, blood vessels down here that can get a small blood clot if someone takes a long flight or if they sit mostly for work and they decide that they're going to stand up after 10 hours, or they stand for a really long time and they don't sit often. Those small blood clots that make their way up into these vessels and into here, as opposed to going through all the paths and the body naturally busting the clot, that hole here can allow that clot to go through. And once that clot goes through and it makes its way into the bottom left room, it hits the aorta, and those first exits, remember, coming off the aorta, go straight to the brain. So folks very early on will have strokes, and that's very uncommon. We see 20-year-olds, we see 30-year-olds who come in and they have a stroke and no one has any idea why. Put an ultrasound on and all of a sudden you see that there's an opening there. And a 20-year-old and a 30-year-old are not going to see their cardiologist, and they may have said, oh, well, I used to have migraines, or I used to always feel short of breath when I was in PE and I was in 5th grade. These are things that patients have told me, and now they say, oh, well, it made sense. So this device is kind of like an umbrella device. So if we have this hole here, half of the umbrella goes on this side, half of the umbrella goes on that side, and it brings it shut like that. And then, again, naturally, our heart, our tissue will develop a scar over it. So now that scar that it couldn't make on its own because it wasn't touching, now we have something in the middle bringing it together, allowing that scar tissue to develop around it. I've got a list of our upcoming studies. Hopefully I'll come back at another time and I'll be able to tell you guys about all these new ones that we have. I don't have the indications on there. Some of them are similar to what we already have. Others are not, but they are able to be found if you look them up on Google or if you call us and you ask. I won't bore you guys with it now, but these are just some of the ones that we have that are upcoming, and these are all cardiac. Our other affiliated programs, just to give you an idea of how big our program is, we do have a research fellowship, and we also have a structural heart disease fellowship. Our research fellowship, Dr. Wagner is the program director, and I'm the lead faculty. We also have the CARE program, which I have a slide on, and I'll show you guys. I created that program. And then we have our GME program, where all of our medical students and all of the residents come through. So we also work with them when we have research rotations, because if not for research and if not for evidence-based medicine, we wouldn't have any of the medicine that we have now. We wouldn't have the interventions that we have now. We wouldn't have the treatments we have now. We wouldn't know the things that we know now. So it's very important for folks as they're going through the process of learning medicine and wanting to be physicians that can really care for their patients. They need to know what the options are, and they need to know what's being tested so that they can make sure that they have the tools to treat their patients, because the way diseases present is really diverse. Like I had said earlier, my heart is different than yours and different than yours and different than yours. So what works for me may not work for you. And all these new physicians that are going to come out to practice, they need to know, well, how would I even find that option? How would I even find out what could work for you if what's on the shelf doesn't work? What are the next steps? This is just a little bit about our research fellowship. It started back in 2020. And then this is our CARE program. This is Compassionate and Accessible Research, which I created back in 2021. Sometimes what's available in a clinical trial would work for you, but there's another reason that you might not meet the criteria for the study. And that's a really hard pill to swallow when I say, have this device and I know it's going to work for you, but there's something else on the back end that doesn't have anything to do anatomically that the clinical trial says, hey, I just can't allow that in my study. That's where this comes into play. So that would be, we reach out to the company and we say, it would be compassionate for us to treat this patient with this intervention. And I understand that because they can't walk 150 meters, they can't be in your trial, but whether this patient can walk 150 meters or they can walk 10 miles doesn't make a difference. Your valve is going to fit and it's going to work and they're going to feel less symptomatic and they're going to feel better. So will you let us do this procedure for this patient? And we make our case and the company comes back and generally they say yes. And they say, okay, we'll talk to the FDA and we'll tell them that we want to compassionately use this device for this patient because what's available on the market is not a good option for them. And we tried all X, Y, and Z clinical trial and it wasn't an option for them. But anatomically, this is going to fit and this is going to work. So we created a program altogether for this so that it can fund projects like this. And it can help us on the back end when we're taking all this extra time to talk to the FDA and talk to these companies about getting this procedure for our patients so it can help us make that actually happen. I promise that's the end of it. Right here, I have Natalia and myself, that phone number there and our email address. I have our business cards here. And then I also have flyers that have links on them. But I have this link here too, and you guys have it on your PowerPoints. If you click on that, that'll take you to TMC's website and the clinical research page on there for patients. And it gives you all these clinical trials as well. And if any questions come up, you guys can always email us or give us a call.
Oh, are you a regular cardiologist? And in addition to this, or is this what you do?
So I was actually the inaugural research fellow here at TMC. I was the first one to graduate the fellowship. And that is my training. So my focus is cardiovascular clinical research.
So,
Yeah.
thank you, Dr. Ehsan. I have a bunch of questions that have come in from our online audience. So we'll address those and then I'm going to turn it back over for your in-person audience. One of the questions I had is, do these trials help balance the gap between men and women for devices available for women?
It's a great question. So there's a lot of trials that actually have initiatives to increase the amount of women that come in because generally women don't go to the doctor. I know oftentimes they say that men don't go to physicians, but women really don't go. They kind of write it off and think, oh, this chest pain that I'm feeling is just because I did X, Y, and Z yesterday, or I did this, or I did that. So what's very nice about a lot of these clinical trials is that they do have initiatives where they really want to bring in more women. And it's mostly focused on the fact that they know women have these pathologies. They know women are experiencing these things, but they're just not being seen. So they're coming to the hospitals themselves and the physicians themselves and telling them, hey, what can you do to bring more women in, to get the word out so that women know that this is an option and that they should come in and see someone.
Great. And how are the implants tested before going to maybe for human trial? What's necessary in order for it to move forward with the trial?
Yeah, absolutely. So first and foremost, the device has to get made, right? And there's a lot of bench testing that's done. So it's done in a lab and there's a bunch of engineers there and they have 3D printed hearts and they're practicing it in those 3D printed hearts over and over again. And sometimes what they'll do is it's a valve, they'll implant it in that 3D printed heart and that's sitting in saline And then they'll make that heart pump and they'll do it 5 million times, 6 million times, 7 million times. And what they're doing is they're trying to see what's the integrity of that valve if this heart pumps 8 million times. So that's how it first starts. And it takes a long time. To get a valve on the market from its inception to being available costs about $500 million, including the clinical trial itself. So a lot of work gets put in, but it starts on the bench. It makes its way into cadaveric hearts, and then it actually, some will do in animal trials to make sure that it can still function that way in a beating heart, and then it makes its way into first in human. So $500 million and 10-ish years to get to being in a trial.
Okay. And then how long are the trials typically for how long then? I mean, particularly for your cardiovascular, what are you looking at as far as when a trial starts and when a trial might end?
Most commonly, it's a 5-year follow-up. So after that first year, it's like a 1-year follow-up with your regular cardiologist. But in general, the trial itself per individual patient is about 5 years. Depending on how hard it is to get patients in, it can be longer for all that data to come out because sometimes it can take 2 years to get all the patients in. But follow-up wise, it's a 5-year follow-up from once a patient starts.
Okay. And is it possible that somebody would qualify for more than one clinical trial? And if so, then how do you determine which one?
So it is possible, but we're not put in those positions. So a patient can only be reviewed for one clinical trial at a time.
Okay.
So I can't have a patient come in and have them sign the consent form for the HeelLaa EFS study and the AltaValve EFS study and the Clasp 2F study. I can't do that because I'm now splitting it up and I'm going to 3 separate companies and I'm saying every single one of you try this, and I've got a patient in 3 separate investigational trials. So we do them one by one. But how do we decide which one is the right one from the beginning? That's based on what's called pre-screening, really. So the cardiologist that's referring the patient to me has looked at the patient's imaging and has either talked to Dr. Wagner or has picked up the phone and called me and said, hey, this is how the patient is presenting and this is what it looks like. Which one do you think this patient would qualify for? Do you think AltaValve is a better option? Do you think HeelLaa is a better option? Do you think the Clasp Clip is a better option? So there's a lot of pre-screening that gets done to make sure that folks don't get put in a position where they're kind of bouncing all around. But it does happen sometimes where we think one option is good. We may think that HeelLaa is a really good option, but when we send the CT scan off to the company and they look at it and they do that virtual implant and they come back and say, whoa, huge gap here, this is not going to work or that's not going to work, then we say, okay, and they know, they're aware of other trials that are going on as well. So then we ask them, it's quite collaborative. Do you guys think that we should try AltaValve or should we try Clasp or should we try this or should we try that? So that way we're all still working together to help our patient feel better and we're doing it as efficiently as possible and as legally as possible.
And so how many, obviously there's a lot of trials that we just went through. How many are we at TMC do we tend to see then in a year that are actually going through a trial? Do you have any idea what the numbers look like on that?
The number of patients or the number of trials?
The number of patients that have been entered into a trial at TMC, maybe in a year.
Oh man, it depends on the year and it depends on the trial. I'll tell you, 2 years ago, we enrolled over 400 patients between 2 clinical trials. So it just depends on the trial itself. If you're in an early feasibility stage and there's only 50 patients total that are going to be done, the numbers are a bit smaller, but there are some clinical trials that have 2,000 patients, 3,000 patients, and we have a huge patient population. So there have been, I've had a year where we've had 400 patients.
Okay. And if somebody is interested in a trial, what are their next steps? How do they get the right information? Is it just talking through their cardiologist, or how does that process work?
Yeah, so fantastic question. I obviously have the contact information here, and one thing they'll be upfront about is if someone picks up the phone and they call me, my first question is, well, who's your cardiologist? Because what we don't want to do is we don't want to take all these steps for your care and not have the cardiologist involved who knows you the best. So we want them to know. What patients can do if they think that something may work for them and maybe something beneficial for them, take that information to your primary cardiologist or to your primary care doc if you don't have a primary cardiologist, and share the information with them. Hey, I saw this. Do you think that maybe this will work for me? And here's the contact info of the folks who are running this trial. I know TMC is running it. So is that something that I can be referred for? And then in that, once we get communication that way, and we know that we're all on the same page, what we don't want to do is we don't want to just bring patients in and not have the physicians who have been caring for them for quite some time know what's going on. So the best way is to reach out to your primary care doc or your primary cardiologist first with options that you think may work. They may already know about the options. A lot of people, heart and vascular folks, it's a huge practice here. So a lot of them know about it. Marshall Cardiology, we also work very closely with. So that pretty much covers all the cardiologists in town and a lot of our primary care docs. We do on our end with the physicians, we do a lot of outreach with a lot of doctors and nurse practitioners and PAs to give them the information on the trial so that they can also know what the options are for their patients.
Great. Okay. I want to thank you so much for being here. I'm going to wrap up with our online audience. I'll turn it back over so that you can answer any questions. And I want to thank you because this was amazing. It was great information for people to know. I don't think anyone realized how many trials were out there and that, there might be options for them. So it was so great to have you here today, Dr. Ehsan. Thank you.
Thank you so much. I appreciate being here, and thanks to everybody online.
Thank you. Thanks so much for being with us today. We will be back next week for Tuesday, March 5th. We actually had a presentation that was rescheduled, and that is help. I've been diagnosed with AFib. Now what? So if you're interested in attending that class, it will be on Tuesday, March 5th at 3 p.m. You can give us a call in the office and we'll be happy to get you registered. The phone number is 520-324-1960. Thank you.